So great, I think really fantastic presentations. And I'm going to invite all of our speakers back to the stage. And we're also going to have Kate Gajewska, who's going to join us. So Kate's a clinical manager for advocacy and research at Diabetes Ireland. So I'm going to sit on the end here, and everybody else is going to scooch along into the middle. And 5 past, okay. 5 past, okay. Yeah. And so we have Slido, and I've forgotten my iPad. So if you have questions, I think before we while you're thinking of your questions or while you're operating the technology, I'm going to go to Kate because she hasn't spoken to us at all yet. So do you want to, given what you've heard, do you want to say anything about this from a PPI perspective, or give us your perspective on what you've heard, and maybe you could just tell people a little bit about, well, so who are you and what's in, one of the many things that's interesting about you in this context.
Yeah, I'm also surprised why I'm here. All these fantastic speakers here and following all these interesting talks. But yes, I'm a person with diabetes, so I live with type 1 diabetes since 1987, so it's more than 36 years now. And the way how research and the development of technology and devices, I think my life just shows how important it is to do it and how significant changes it does. So my life with diabetes when I was newly diagnosed, My life with diabetes when I was newly diagnosed was very tricky. Like, I was 16 months old, so my parents, they had to care for me, but they had no tools to care for me, really, because they had no accurate insulin syringes. They had no blood glucose meters. So for the first 4 years of my life with diabetes, the risk of having severe hypoglycemia or any other severe condition, or even the risk of developing complications was just 100% really. So my parents were absolutely sure that I will not be able to have children, that I will not be able to live full and healthy life by the age of 30, and I probably will die by the age of 40. So that was the message. That was the message that my parents had. But when I was when I was 5, so it was 4 years with living with diabetes, my dad went to Germany, because I'm Polish, we used to live in Poland then. My dad went to Germany, he worked on a strawberry farm, he collected some money, and he bought me a blood glucose meter, which was available in Germany, but wasn't in Poland. And that was a huge game changer. That was the first technological game changer that we had, because finally, for the first time ever, my parents could have seen what is my blood glucose level and possibly react. Unfortunately, they couldn't react too much because we still had very, very old school insulins. So for the first 12 years of my life, I had to eat. I had to be on a very, very strict diet. I had to take 2 injections a day, but I had to eat every day the same. So then another super big change in my life was related to modern insulin analog, which changed the way how I eat and how I can live my life. Because finally I could have delivered insulin to the food that I want to eat and for how much I would like to eat. And it was a huge game changer. And another one was insulin pump therapy, next continuous glucose monitoring system, and finally automated insulin delivery system. So something that consists of insulin pump and continuous glucose monitoring and informs the automation of insulin delivery. So I don't have to think as much of diabetes as I used to think. I'm much more safe. And yeah, my life with diabetes is definitely easier now. So absolutely, technology and research improves people's lives dramatically.
Great, thank you. So I'm going to encourage the audience to either you can put up your hand and I'll try and see you. I'm not sure if is that a hand? Do you think?
There's one over there.
There's one over there. Ah, very good. Okay, super.
Sorry, I have a question for Sally Ann.
Yeah, sure.
Fanula Barnack, and I may have misunderstood, so at the risk of exposing some degree of non-compliance on the part of where I work, so I won't say where I work, but just you mentioned non-availability of genetic results on hospital systems. I wasn't sure what you meant by that in terms of...
It's just
like, for example, even in Crumlin, people cannot see our chromosome array test results. So it causes huge amounts of problems. Now, you have to be, the DPO would be all over us for protection of results. So, for example, something like a Huntington's result should never be available to everybody within a hospital. So you have to have protection on test results. So in Crumlin, the test results are only available to the clinical genetic staff and the laboratory staff.
And is that all genetic results? Or?
Well, even in the NHS, they have you know, your certain people are allowed certain access. So they have access limitation within the NHS.
Yeah.
And you will have to build that in, but I would love the tests to be easier available, because we end up with this business of people repeating tests, not realising it's already been done. And so I've done a bit of research on that recently, which we're hoping to publish on the mess that is accessing genetic testing, because it causes huge problems for clinicians all over Ireland.
Okay.
But
because our results, as you may know, our paperless system.
But in a fetal medicine unit, probably isn't so
relevant.
It's more things like predictive testing, Huntington's, adult onset disorders.
Fine.
Yeah.
Fine. Okay.
Great, super. So we have lots of questions here. We have lots of questions in the audience. I'm going to go to the audience, given that there's so much enthusiasm. So we'll go to this gentleman first, and then there's a question over here. Maria has a question too. So go ahead. And in the interest of making sure everybody gets to ask a question and we get to the slider ones, keep the questions brief if you can.
Thanks very much. Robert O'Connor, Director of the National Clinical Trials Office. Firstly, because it hasn't been said already, can I congratulate the individual or team who brought together all of the speakers today. Every single one has made me think in new ways. And especially this panel, of course. And secondly, I always love a few sci-fi references, so thanks to the guys for getting those in. I suppose the general question, and I'm going to bring two things that I know are very separate, but are, I suppose, continuing to evolve and emerge. I've been 30 years or more in research, so I've been involved a lot in ethics, and more recently seen a lot in data protection. To what extent do members of the panel think that they're starting to become a little bit like politics? They're emerging, and they're maybe, to what extent are they disconnecting from the realities of the community that they're seeking to support, protect, or represent? And they're two separate areas, I know, but I'm trying to, given the times, so ethics and data protection. For example, we don't have any survey on data protection views in Ireland, certainly in health, nor even within the EU, and yet lots of decisions are being made around that. And the table was fantastic, showing the divergence in views, which is impacting us hugely in things like clinical trials.
Great. Who wants to take that? Would you like to go with David?
Can I make a point then about informed consent and link it to this question, because it came up this morning. And one of the clear problems about informed consent as it now operates is that it's coming increasingly into conflict with the imperatives of those who are doing the fundamental research. So earlier this year, when in Stockholm, somebody from the Karolinska Institute gave a talk to all the ethicists of the EU and said, I've got informed consent to obtain data and samples, but I can't use it, and I can't correlate it with other forms of information I have, simply because they never gave consent to that particular use. And it was an accusation to us. What's the point of informed consent? It's just blocking research. And that's a complaint you frequently hear. So I think the really difficult question is, why do we value informed consent, to be slightly provocative? And it's important to note that those who spoke this morning stressed that it arose in part after the war as an attempt to ensure that certain abuses of medicine never, ever occurred again. And I had the misfortune to go to the Museum of the Japanese Occupation in northern China in Harbin. One of the worst experiences of my life, just to see the evidence, real evidence, film and photographs. So there is a sense in which informed consent is a prophylactic. It serves as a protective, preventative instrument. But you can say, well, if we've got other forms of protecting, why do we need consent to do that job? The other reason we value consent is a fundamental expression of individual autonomy. The fact that an individual is sovereign over their mind and body, as John Stuart Mill famously said. If you think that's the point of informed consent, you will never compromise.
Do you think there's a difference between, do you think informed consent might be could be weakened in the context of academic research versus commercial? Do you think that commercial versus academic public good changes the discussion a little bit or at all?
No, because either you...
Don't unequivocate.
No. I mean, informed consent, if you take it seriously, and by the way, most philosophers don't understand what the informed is doing in front of consent, because it's not consent if it's not informed, okay? If you don't talk about informed consent to sex, you don't talk about informed consent to political states. It's just consent, full stop. If you think consent is one of the most fundamental expressions of individual autonomy, there is no amount of public good that will ever trump it. And one of the problems you've got is appeals to consequences and balancing of consequences come up against this real brick wall of individual rights. So either you take individual rights seriously or you don't.
Fantastic. Anybody else want to come back on this question? Yeah, Michaela, go ahead.
I could not agree more, and we see in practice also the challenges, of course, of consent, and I would argue that informed consent is important as regards to the GDPR, especially when there is the legal argument to it, because if we cannot justify ourselves but shift the responsibility to the one who is consenting and saying, we don't know, but as long as you give us your consent, we can now legally do whatever, then the consent is clearly flawed, and then you should not do it, and you need to reconsider. Yeah. Or you need additional measures and also understand consent as a process. We have that discussion when it comes to data usage, because today, anonymity is seen as a temporal concept that might be true with certain technical measures in a specific context today, which might be completely different in a different context, and as technology moves so fast ahead, changes probably tomorrow. So anonymity and anonymous data is certainly not the solution when it comes to the GDPR. Anonymous data, of course, being outside of the GDPR to some extent, because if it's anonymized, it should not concern the GDPR. However, again, as we don't know how long the data can remain anonymous, it might be identifiable data tomorrow. We need to reconsider. And I want to close this with a Netflix reference. There is this beautiful series on the Charité that tells the early story of the pathologists Virchow and hygienist Koch, how they fight within the institute. And there's this fantastic scene where Virchow, the pathologist of the day, the modernizer, is in the auditorium with all the ongoing pathologists looking at a body, having no clue about hygiene, and they look into the body with grab into the body with the bare hands and very gentlemanlike. And the image stuck with me because I feel that's how we deal with data today. We think we know how to deal with it, but we have to be honest that we just don't, and that's okay as well, because it's part of research to admit we don't know and figure out ways how to handle it.
Very good, thank you. Murray, you have a question there. And there's a question at the back then, and we have some on the screen, and we have one in the middle. So Murray, a gentleman in the back and the girl in the middle then. Okay, go ahead.
Hi, thank you. It was a question for Sally-Anne and regarding the consent as well. You said that the data, for tests like Huntington disease is kept private, it is not shared. So what do you think about the data not being accessible to another consultant within your institution, or in fact with another institution, another hospital, which going to impact the way this consultant is treating the patient, not knowing that he has this disease? And the second thing relating to that is, at any point, do you ask the patient if he's agreeing to his data being made available to other consultant in other, facilities? Should he seek care in other facilities? Is the patient consulted for that?
So I suppose that the laboratory would observe good practices, and if somebody from outside was looking for a result in a patient that they hadn't sent the sample in on, they would get that doctor to get the patient to agree to it.
Okay.
If they don't know, the patient doesn't know that test, or is not realizing that it's a genetic test, and the consultant doesn't realize that test has been done,
Well, that causes this business of duplication and stuff that goes on the whole time. So I do think it is important that people are able to, who work looking after patients, are able to access those test results. And it's just, and it's not rocket science. They do it in the NHS with access limitation to make sure that the person who's looking for it is bona fide. Because if you have Huntington's in your family, you don't want somebody in a totally different specialty who's no business looking at your result to be able to access your result. Yeah. So it is possible, but it does impact patient care if you can't access results either, a genuine person. Which it's very difficult to access stuff at the moment because the IT systems are all not interoperable between hospitals. Everything's different. Every IT system is different. The laboratories don't have any, don't even have a good IT system themselves. HSE wise.
Good. Thank you very much.
I think it with access, with good access and bona fide, that's fine. That's fine.
So so the gentleman in the back, and then there's a lady in the middle, and then there's a lady in the back, and then we go to the questions that I hope are not ChatGPT generated. So the
thanks, Chair, and thanks to all the panel. This excellent session. I'm Donal O'Connor. I'm the clinical manager for medical devices in the Irish regulator, and I'm the co-chair of the European Commission's Task Force on Orphan Medical Devices. Moving a little bit away quickly from maybe the consent and the data protection and integrity, a more general question around, I suppose, the ethics of new technologies, particularly some of the examples given in Prof O'Keefe's talk. And I'm having a bit of maybe an existential ethical crisis as a regulator in that tension between over or under regulation and protection of the public, and that tension about allowing new technologies that will benefit large populations. So we've got a nice example there of the problems with under-regulation or lack of regulation, where we have a device, an AI software, doing genetic testing or something on people, and it's not validating, producing very spurious results and clogging up the health system. But I'm also aware in the examples of the glucose monitoring systems, there are unregulated but very good intended, with a lot of efficacy behind them, open source, transferring and sharing among people with diabetes of technology, and plenty of data showing that it keeps them in those parameters that Prof O'Keefe talked about there. So I'm just wondering if maybe Prof Archard or O'Keefe have comments on where that tension relies on how, we have a responsibility to regulate to protect the public and broader populations of patients, but there's a bit of a tension there where if we over-regulate, we slow up the implementation of the new technologies or the onboarding and the testing in the clinical community, and that's itself, if it's not done carefully, it could potentially be unethical.
Yeah, sure. So, you don't go ahead.
Yeah, so great question, thanks. So, and I guess this goes back to the duality of technology. So a fire will keep me warm at night in my house, but it'll burn my house down. I make a knife to butter bread, but I can use it as a weapon. So there is that duality of all technology, just it's a part of technology. I think that the most important thing to take away from today is that think of AI like electricity. Okay, so electricity can kill you, but if it's regulated and it's standardized and it's used appropriately, it's probably the most powerful tool we have on the planet. And AI needs to be the same. Everything we do with humans and human health needs regulation. So you think of water safety, food safety, driving safety, everything, the safety of this room, the fire safety, we regulate it, and therefore we should regulate AI. It's a no-brainer.
David, do you want to come in on that? Your microphone might be working.
Is it? Oh. Well, just a quick point. I think one of the ways that you can ensure that regulation isn't over or under is actually to secure proper public engagement. Because I do think that if the public understands what the purposes of regulation is, but also understand what the science is, then you can move in the right way. And just the quick example, when the HFEA was asked by the government to conduct public consultation on mitochondrial treatment of diseases, it was over about 2 years and involved an extensive series of workshops. When it came to the vote in the House of Commons, it just went through on the nod that we should license it, because the public by then was much better informed about what it was and what awful conditions those are, and how easy the process is. So I don't think it's science on one side, regulator on the other. There's a third party, and that's the public.
If I could just add a comment, I think one of the challenges with AI in particular is that it's very fast moving and it constantly surprises people. So there are papers, for example, that there is work that can predict quite accurately the sexual orientation of individuals from facial photographs, right? So, and I think that surprised people when that work was released. There's all sorts of things that surprise people. And the other thing about the technology is that not only does the language change, but the nature of it. If you look at the European AI Act, and I was involved in that in the very early days, they did not see large language models coming so quickly. They did not expect to see foundation models come so quickly. And there was a bit of an existential threat in Brussels, existential moment in Brussels about a year ago when they realized this bloody act doesn't fit AI as we know it today, right? So that's also the challenge. How do you make sure this regulation in the context of AI keeps up with the technology? And that's really, really difficult. The lady in the center right there. And then there's another lady at the back over there.
Thank you. My name is Laura. I'm a postdoctoral scientist in RCSI at the Future Neuro Research Centre. I have a special interest in genomics, so this is also an AI-based question. Correct me if I'm wrong, but my understanding of machine learning is that we don't have an excellent grasp of what the machine is learning and how it's coming to the conclusion that it comes to. So I guess I'm wondering to hear the panel's opinion on how much of an ethical challenge is that, not having a clear understanding, especially in terms of genomics. The genome humbles me every day in what we don't know about it. So if a machine is learning something based off the genome and that's eventually going to impact a clinical decision, how ethical is that at this point, and what's your opinion on that?
Jerry, do you want to take that one?
Sure. So it's a great question, and it goes to the heart of why there is so many ethical wranglings with AI. There's a paper from the Mayo Clinic last year that showed a picture of a retina, the back of a human eye, and you can get the best consultant ophthalmologist on planet Earth to look at that, and they won't be able to tell you the sex of a patient. They'll be able to tell you if there's a disease there and so on, but they won't tell you the sex of a patient, and the AI can. So there's something in that data that we can't see, some pattern that we can't see at the pixel level that the AI can, find out to a very high level of accuracy because it's been trained. And we've no way of knowing that. We're moving away from the traditional heuristic models of computer programming to this black box, as you said. And that's quite frightening when you don't know, how it actually works under the hood. And it's across all areas of AI, and especially in healthcare. But even driving your car, machine learning is used to keep you inside the white lines. They're not really sure how it does it, beyond our rudimentary understanding as humans. So I think the pattern matching is what we're talking about here. It's what AI is for the next decade at least, until it becomes multimodal. By that I mean lots of different inputs and outputs, so speech and text input, like you have your ears and your eyes, and then obviously actuation, like when you can touch things like a robot. That's when it's going to the next level. But until then, the black box thing is probably the biggest ethical challenge of AI.
I'll go to the lady over there next, but just a comment on that. I think the reason this black box thing isn't true of all AI systems. AI is a hugely broad field, and machine learning is one subfield of AI, and the black box AI systems are one subfield of machine learning. And these are the deep learning systems, neural networks, and obviously the new systems that we see, the foundation models, the large language models, they're largely based on that kind of technology, and that is certainly not explainable. But there are lots and lots of AI systems that are perfectly explainable. But I think the problem is that the ones that are most successful are the ones that are least explainable. And I think one piece of advice I would give to anybody is make sure you choose the method to fit the application. If the application requires that you can explain something, then don't choose something that's black box, because you won't be able to do it, right? There's a lady at the back, and then we'll go to the screen if there's no other questions.
Hello, I'm Camille, and I want to come back again on the access for other physicians, for genetic testing. This brings me other questions regarding patient access with their own diagnosis. Do they have really access to the diagnosis? Why do they get? Is it only a verbal access, or do they get like something from the laboratory, and then after they can bring it to the other physicians if they want to, and like being the patient, the actor actually of the transition of the information about them. So how do you do that?
So I might just answer this quickly. I worked at the Mayo Clinic for a number of years in America, where you had an e-health record, both the patient and the clinician. For example, for genetic testing, if I wanted to access it, it would be there in the system, and I could double-click to request it, and if the request was valid, I was allowed to access it. Same with psychiatric history, for example. Some things were not just on general review to general clinicians. Interestingly, if the patient has it, that kind of makes sense to all of us. We should have access to our healthcare records. One of my last ward rounds at the Mayo Clinic, I walked around into the patient's room, and they said to me, "Doc, I just got my CT abdomen back, and it says I have a 3 centimetre growth in my liver. What does that mean?" because they were able to see their result. So then they started to realize, wow, we can't actually send results out to patients without somebody having clicked a button saying, yes, I've explained this to the patient. In that case, it was a benign angioma. But the point is that you need to have context for data. So I get a lot of phone calls about sodiums of 134, and I'm able to say that's not clinically significant, even though it's in red on your reference range. And that's really important.
So do you have a smartphone?
Yes.
So in clinic, what I do is, here's the report, take a photo.
Okay.
So every patient in genetics is given, as long as we remember it, is given their report, because for certain conditions, a specific mutation, I should call it variant, might be amenable to treatment and others won't be. So I spend my time on my patients' smartphones.
Right. Okay, so I'm going to take one more question from the audience. David's had to leave, he's catching a plane, but he recommended anybody who wants to follow up with him, you're welcome to email him. So this lady here. And then we'll just rapidly fire through some of these, because I think there's just maybe 2 or 3 different topics, and we can cut through those pretty quickly.
I'll make it super quick. I just wanted to follow up on that lady's comment. I've had MS for 13 years now, and every year I get an MRI, and the last time I went, they handed me a CD with my MRI in it. I don't have it. I don't have it. Who does? We're not in the 90s anymore. And anyway, when I did buy the external CD
Reader.
drive, like what you're saying, you have a 1.5 centimetre lesion on your brain. Oh, you have 30 lesions on your brain. Oh, is that a lot? It's the translation of the data, which we do have access to, which is brilliant, but we just need to translate it down to the patient's level. Thank you.
Great, thank you very much. So we have some questions here, and we're going to go through them very quickly. I can imagine the answer to the first one. What do you think of private health insurance companies giving DTCs for free?
Can I ask the audience to answer that for me in a way? And because do the audience think that a HSE publicly funded genetic service, which has a waiting list of 18 months, should take on Worried Well or not? Yes, please put your hands up. No? Fair. Okay, but we're stuck. We're stuck having to pick these up, and most of you think we should say bye. Well, that gives me a bit of confidence to say bye.
There we go. Now. And the next one isn't likely that DTC testing isn't going anywhere. How can this data be ethically used in research and healthcare?
Well, the research. That test that I was talking about that isn't very good. I still think it's a baseline research, and then if you were going on to try and validate the variant, you would do different technologies to do it. So I still think it's ethically okay in research. I just don't think it should be used in DTC.
And there's 2 more questions about this. How important do you think genetic counsellors will become in the future?
Going back to that question about the MS, a genetic counsellor isn't going to be looking at your MRIs, but they will help interpret, and no matter how much an AI is, a machine won't be examining the patient. So you'll still need somebody to interpret the variant.
Right, and that's a big question. Would it not be better to disclose incidental findings as long as the degree of uncertainty
So again,
is?
incidental findings are disclosed. So that's the difference. Incidental findings are definitely disclosed. It's the secondary findings, the purposeful search. So I'll just give you trying to give you an idea about this. For example, if you find a secondary finding, something like a cardiac gene, a sudden adult death gene, if there's no family history, the penetrance is so low that you probably wouldn't screen for it. And the American College of Cardiology, the American Society of Cardiology, and we're talking America here, they have now said that if somebody has a positive secondary finding for a cardiac condition, sudden adult death, and their heart screen is perfectly normal and they've no family history, that they do not advocate screening the relatives. So the American Society has shown that. It just shows you what a low risk factor it is, and we're scaring people to death about something that actually possibly isn't a risk for them. It's just we're not able to interpret them accurately enough to give advice. So that's the issue. Okay, good.
To Derek and to Kate and Michaela, so what are the challenges in obtaining informed consent for conducting research in AI, and what are the strategies that should be implemented to overcome them? I guess, just briefly, what do you think the biggest challenges are? Briefly.
Briefly.
One challenge.
So the challenge is The challenge is trying to define exactly what you're doing with the data, and then getting ethical approval just for that, and that's then informed consent. That's the biggest challenge.
Great. So, go ahead.
The challenge is also to bring the actors together, and I believe that's where networks are important, research networks, biobank networks, and I want to use this time also to say that what I've experienced here as an Austrian representing an international research infrastructure here in Ireland, you are doing fantastic work, and I know that the grass in the neighbor's garden is always greener, but what I see in Ireland, it's pretty green here.
Right, thank you.
On the question of consent, I fully agree here, because big data and the best consent template does not solve the question. It's not, the question is always what is the purpose, what is the goal, what do you want to achieve with the data at hand?
Great. Thank you. I just want to thank the panel. I think it's been really fantastic, so let's give them a round of applause.